Hello, my name is Maria Ragusky, and I will be speaking today about adult syringomyelia. So the objectives of this talk are first to review the definition and epidemiology of syringomyelia, second to review briefly the pathophysiology and the clinical presentation, and then to speak about the common etiologies underlying the development of syrinx. And lastly, we'll talk about some treatment strategies. Syringomyelia is a cystic dilation of the CSF within the spinal cord. It's associated with multiple underlying etiologies like Chiari malformation, which represent about half of all syrinx, post-traumatic. Among the traumatic spinal cord injury patients, the majority will develop a syrinx, but very few eventually become symptomatic. It can be associated with arachnoiditis, as well as a group of other conditions like intramedullary tumors, degenerative disease, arachnoid webs, or tethered spinal cord. And lastly, it can be idiopathic. This MRI is a sagittal T2 MRI demonstrating a traumatic injury with laminectomy and a distal syrinx. As far as the incidence and epidemiology, this is typically children and young adults. The prevalence is 9 per 100,000 population, and an incidence of 0.44 cases per year. This is likely an underestimate of the true prevalence and incidence, as these were derived prior to the routine use of MRI. There may be some regional and ethnic variation, as certain series from Russia have reported a very high prevalence of 130 people per 100,000 population. There are multiple theories regarding the pathophysiology and development of syrinx. One of the most common is the hydrodynamic theory, where unbalanced CSF pulsations result in unequal pressures between the supratentorial and infratentorial spaces and a differential pressure between the cranial and spinal compartments. This results in fluid accumulation within the spinal cord. Some authors have postulated that a subarachnoid block in the spinal cord reduces the compliance and results in a differential pressure between subarachnoid spaces and intraparenchymal tissues, and this results in buildup of fluid. There may also be an inflammatory response due to other pathological insults such as trauma. And lastly, ischemic changes may lead to the coalescence of cysts that occur due to impaired CSF flow and cystic degeneration. Syringomyelia can be classified into 4 different groups. The first being class 1, which is a communicating syringomyelia. This is central canal dilation and can be associated with communicating hydrocephalus, complex hindbrain malformations, or Dandy-Walker malformations. Class 2 is non-communicating. This again is a central canal or paracentral syrinx, and this can be due to Chiari malformation, basilar invagination, spinal arachnoiditis, either post-traumatic or post-meningitic, extramedullary compressions from tumors or cysts, tethered cord, or acquired tonsillar herniations from hydrocephalus or intracranial mass lesions. Primary parenchymal cavitations from trauma or ischemia infarction and intramedullary hemorrhage are also classified in this category. Class 3 would be atrophic cavitations or syringomyelia ex vacuo related to myelomalacia. And Class 4 would be neoplastic cysts or cavitations. The clinical presentation of syringomyelia initially starts with a dull or burning pattern of sensory loss due to spinal thalamic tract involvement. This is classically suspended or cape-like in distribution with a dissociated pain and temperature loss, with intact light touch and proprioception due to late involvement of the dorsal columns. Later, weakness can develop due to involvement of the corticospinal tract as the syrinx involves the ventral horn, and this can be asymmetric due to a variable degree of ventral horn involvement on each side. Later, other symptoms like autonomic dysreflexia, Horner syndrome, and hyperhidrosis can occur. Clinical progression is typically slow, although sudden worsening has been reported due to hemorrhage into the syrinx cavity. Clinical stabilization has also been reported after a period of progression. The treatment strategy ultimately depends on the underlying etiology, and we'll go over this briefly. This algorithm demonstrates a stepwise approach for workup in cases of clinical suspicion of syringomyelia. When clinical symptoms suggest syrinx, an MRI without contrast is recommended. If there's a structural lesion, such as Chiari malformation, trauma, tumor, or arachnoiditis. Treatment depends on whether symptoms occur or whether symptoms stabilize. If a patient is asymptomatic or symptoms have stabilized, monitoring or addressing the underlying structural lesion is indicated. If the patient is symptomatic, then addressing the underlying structural lesion is the treatment course. If there isn't a structural lesion, further imaging is indicated, and this can be CT myelogram, which is relatively controversial, or a scene MRI with phase contrast with or without EMG and nerve conduction studies. If the patient is asymptomatic or symptoms have stabilized, again, clinical surveillance would be the treatment course that is recommended. And if the patient is symptomatic or becomes symptomatic after a period of being stable or asymptomatic, then an evaluation for etiology is indicated. If this is related to arachnoiditis or a local lesion, you can consider arachnoid lysis. If there's extensive scarring or unclear etiology, you can consider a Syrinx shunt. If there's a focal lesion or scarring and arachnoid lysis is performed and symptoms fail to improve, or Syrinx size does not decrease, or there are recurrent symptoms, then a Syrinx shunt can be considered. Regarding post-traumatic syringomyelia, this is generally related to spinal cord injury. 50% of patients with spinal cord injury develop spinal cystic change, with about 21-28% developing a Syrinx over the 3 decades following injury. Only 1-9% of patients with spinal cord injury develop a symptomatic Syrinx. There are some unique mechanisms in the pathophysiology in post-traumatic Syrinx. The initial injury results in an inflammatory response and localized spinal cord edema with cyst formation. The cystic cavity can remain after absorption of an intramedullary hematoma. There may also be a possible ischemic mechanism, as there's a predilection of the Syrinx for vascular watershed regions of the spinal cord. And then lastly, subarachnoid adhesions, deformity, and spinal stenosis are all commonly seen in spinal cord injury and predispose to Syrinx formation. Regarding arachnoiditis, this refers to scarring of the peel and arachnoid membrane secondary to chronic inflammation. The severity ranges from focal adhesions or a arachnoid band to dense scarring, and causative triggers involve infection, history of spinal stenosis or myelopathy, subarachnoid hemorrhage, degenerative lumbar disease, previous spine surgery, steroid injections, or remote history of intrathecal contrast. This is generally delayed in onset from the initial causative trigger. Some MRI findings that are seen with arachnoiditis include grade 1, which would be conglomeration of adherent nerve roots residing centrally within the thecal sac. Grade 2 would be peripherally adherent nerve roots and an empty thecal sac appearance with meningeal thickening. And grade 3, which would appear as a soft tissue mass within the spinal canal with obliteration of the subarachnoid space. The diagnosis of arachnoiditis can be difficult, and an MRI would be the first study ordered in most patients. Sensitivity and specificity have improved with thinner cut, heavily T2 weighted MRIs. CISS images better visualize dural thickening, syringomyelia, and microcystic change within the spinal cord. If there is a high clinical suspicion without an alternative explanation of the patient's symptoms, you should consider myelography to further evaluate them. This sagittal CISS MR image demonstrates a T2 to T6 Syrinx in a dorsal arachnoid band that is demonstrated by the arrow. Arachnoiditis can be difficult to treat. Surgical treatment is generally deferred until progressive neurological decline or the patient is in severe pain. Close clinical follow-up or monitoring is reasonable, as many patients are asymptomatic. The surgical treatment is often tailored towards an underlying mechanism. Surgical options include lysis of arachnoid adhesions with or without duroplasty, as well as shunting procedures such as syringocavitary, syringosubarachnoid, or lumboperitoneal. Release of adhesions with duroplasty may have favorable rates of reoperations and time to clinical recurrence compared to shunting. However, patients with extensive scarring fare worse with release of adhesions and may be better treated with shunting up front. Klecamp et al. Demonstrated that 17% with severe scarring stabilized following arachnoid lysis versus 83% with mild scarring. So the extent of scarring is a strong clinical predictor of how patients do following release of adhesions. Goranmohammed et al. Performed a systematic review of 12 studies with 410 patients with primary syrinx. Arachnoid lysis was associated with longer duration until symptomatic recurrence, and they did not find similar associations for CSF diversion methods. Kleekamp et al. Published a study of 67 patients undergoing treatment for progressive symptoms. 97% of shunted patients had recurrence versus 22% of patients undergoing duroplasty and arachnoid lysis. Overly aggressive arachnoid lysis in the setting of severe scarring can, however, lead to neurological worsening. Syrinx shunting does, however, have an important role in the treatment of syrinx. Options include syringocavitary, syringosubarachnoid, and lumboperineal shunts. Of 15 patients undergoing a shunting procedure, 60% did improve. However, 8% required further procedures, and only 31% demonstrate clinical improvement following repeat procedures. Davidson et al. Published a series of 41 patients undergoing syringosubarachnoid shunting. 98% did have stabilization or improvement of neurological signs and symptoms, and there was a 7% recurrence rate, which was lower than previously reported. So certainly syrinx shunting does have a role in the treatment of syrinx. There are some drawbacks of syrinx shunting. The potential benefits must be offset by the relatively high rate of complications. Of 42 patients undergoing syrinx shunting, 50% developed a complication or shunt failure, and some potential complications include neurological deterioration secondary to myelotomy, spinal cord tethering related to the shunt, CSF overdrainage, as well as meningitis, pneumothorax, or brachial plexus palsy. The major take-home message for syrinx treatment is that etiology matters. So for post-traumatic syringomyelia, correction deformity, spinal cord decompression, and spinal cord transection all have roles in the treatment of this. Foramen magnum obstruction really is best treated with suboccipital decompression, and syrinx-related spinal tethering due to fatty phylum is best treated with phylum terminality release prior to addressing the syrinx itself. The conclusions of this talk: first, syringomyelia is a distal dilation of the spinal cord, which is due to a myriad of diverse pathological processes. This is frequently asymptomatic, but leads to chronic progressive neurological deterioration when symptoms occur. There are many surgical options available with modest outcomes, often requiring multiple procedures and neurological deterioration despite treatment. Stabilization of symptoms and avoidance of further worsening are the primary goals of surgical intervention. This slide has a few suggested readings with full references provided within the chapter. Thank you.